Welcome to another episode of The Synapse, bringing content that matters to the busy medical professional. With us today we have ENT surgeon Mr. Adrian Agius, who will be speaking to us about common chronic facial pain. Mr. Adrian Agius, how common is facial pain, chronic facial pain?
In ENT practice, facial pain is extremely common. If you look at patients who come with problems related to their noses, whether it's blocked nose or rhinorrhea or itching and so on, 25% of all patients presenting with rhinological complaints have some form of facial pain. Facial pain can be divided into acute or chronic pain, but we are today going to deal with the chronic variety. When you look at the chronic variety, we are now very lucky to be able to refer to two very important publications, one of which is the International Headache Society classification of 2013, and the second is the European position paper of 2007, which was updated in 2012. So I have two publications which are very important European and international guidelines, which have happened together in the past 2 years.
And what did these publications elaborate on specifically?
So the International Headache Society classification deals about pain which is primary pain, whether tension type headache or migraine, for example, and secondary pain related to, for example, sinusitis and other causes. Whereas the European position paper deals about the criteria that we adopt when we diagnose chronic rhinosinusitis. And I say chronic rhinosinusitis or CRS because CRS is usually the automatic diagnosis of the medical professional when faced with facial pain. These are usually patients who are women in their mid-30s who complain of pressure on the forehead, on the nasion area, on the cheeks, which is a constant nagging pain, not severe, mild to moderate. However, it takes up 6 to 8 hours of their day, very frequently occurring, and we usually, for some reason, have ascribed it to sinuses. Why has this occurred? This has occurred because during research carried out in the 1940s, two professionals stimulated the nasal mucosa in some normal people, and the patient responded by pointing to areas on their face. For some reason, because of this one particular piece of research, which was only limited to less than 10 people, individuals, the pain, the electrical stimulus was referred by the patient to these particular areas. So the classic areas that we associate with sinusitis, for example, ethmoid sinusitis in this region, sphenoid sinusitis in the vertex. These are all coming from this particular research carried out by an individual called Wolf in the United States in 1942. This happened. So we are laboring under a false impression. In fact, this particular research was repeated a few years ago with completely different results. When you look at patients with sinusitis, clinically proven sinusitis, where you have CT evidence and nasoendoscopic evidence with purulent discharge inside the nose, only about 20% of these individuals actually have facial pain ascribed to the sinusitis. So sinusitis actually very rarely causes facial pain. When you look at the cohort of patients who present to you with facial pain, most of these, about 60% of these, have a normal CT and normal nasoendoscopy. So it means that the cause lies elsewhere. And we now know that the cause is mainly neurological.
So those are the most common causes, the neurological?
Yes. And it is known, it is this pain which is symmetrical, bilateral, pressing, occurring almost every day, taking up 6 to 8 hours, not related to photophobia, not related to vomiting. Patients don't have an aura. It's not exacerbated by exercise. This is a tension type pain, but occurring in the face. So it's like tension type headache, but with a different distribution. And I mentioned photophobia and vomiting because these are salient features of facial migraine. And this is the second most common cause of facial pain in such individuals. So, if you look at patients who come to you with facial pain of a chronic variety, most of these are going to be tension type pain. And a minority, about 25%, are due to facial migraine. And the facial migraine, the most common features would be the patient suffers from a throbbing type of pain in the face, usually on one side in 50%, but it can be both sides or it can be alternating. So that's very commonly migraine. They may have an aura, they may have phonophobia, but they usually have photophobia and vomiting. So this is a very important feature of facial migraine, together with the exacerbation on exercise. If a patient with migraine tries to walk up the stairs, their pain gets worse. So these are the two main types of pain,
causes,
apart from sinusitis. So if you exclude sinusitis by doing a nasal endoscopy, which is normal, carrying out a CT, which is normal, and then the main types of pain after that are going to be tension type pain of the face or facial migraine.
Sinusitis still remains number one. These are then after sinusitis.
No, sinusitis is if you have a cohort of patients who present with pain to you, 60% of them are going to have a normal CT, a normal endoscopy.
So they're just neurological.
So
then?
these are neurological,
Okay.
and of these neurological variety, most of these 65% are going to be tension type pain, 25% facial migraine.
Are there other causes of note, even though they're rarer?
Yes, there are neuralgias, for example, trigeminal neuralgias, glossopharyngeal neuralgias, both trigeminal and glossopharyngeal at the same time. You can have cervical spondylosis, which causes pain in a similar distribution, and also very commonly we have to exclude dental and temporomandibular problems, which also cause problems usually on one side of the face. They're related to bruxism, for example. They're related to if you tap the teeth, the teeth hurt. The teeth hurt when you have cold or hot drinks. So there are clues as to whether the pain is of dental origin or not. In fact, when you look at orofacial pain, this is a subject which is completely on its own, and the oral surgeons now recognize that there are such entities as neurovascular pain of the oral region, vascular pain, which is a bit like migraine, to make things a little bit more confusing. When you take a proper history, facial migraine, for example, often presents also with rhinorrhea, or with sneezing, or with nasal congestion. And this is because the parasympathetic nerves are involved. So it's very important to take a good history so that you can actually separate what's going on, because facial migraine mimics sinusitis because of the parasympathetic activities going on.
Mr. Agius, we mentioned a number of different diagnoses. How would I differentiate whether they're urgent or acute? What are the red flags?
Nothing is easy, but it's very important in your examination, for example, to do the basics. So you take the patient's blood pressure to exclude blood pressure problems. You look at the optic discs to make sure that there is no raise in intracranial pressure. Carry out an examination of the cranial nerves. So these are things which you can do in your physical examination. However, in the history, patients whose pain wakes them up at night, for example, who have severe and daily pain, these are patients, or when it is related to position. These are, or for example, sneezing. When you have a rise in intracranial pressure due to sneezing, the pain gets worse. These are conditions where one senses a little bit of alarm, and your threshold to investigate is diminished. So in these cases, you might have to carry out some form of imaging, either MRI or CT, to exclude any other medical problems. However, having said so, in the cohort of patients that I have studied, where I scan these patients, occasionally come across tumors in the brain which have hardly any symptoms at all, especially if they are early and if they're small. So I think we can't find a perfect mode of treating these patients. Is just to have a high index of suspicion.
Exactly, that's your tip then.
Yes.
And now, with regards to, so we've managed to get the differential diagnosis. Now on to treatment, as in the diagnosis phase.
Yes.
On to treatment. What's
So,
specific?
so this is the background. So you generally in ENT we would see patients who present to us with chronic facial pain, which is more than 15 days, a month, for 3 months, pressure, tired, possibly related to position, although this key feature that many people rely on, which is pain getting worse on bending, that is not specific to sinusitis. It can also occur in neurological conditions. So when you have the patients with this general type of pain, what we usually do, we carry out an examination, nasal endoscopy, and if the endoscopy is normal and there is further doubt, you carry out a CT of the sinuses. If these are all normal, then it's worthwhile to treat the patient with an 8 to 10 week course of low dose amitriptyline. So amitriptyline in a dose of 10 milligrams a day very rarely upsets the patient, and you can explain to them, this is how I explain to them, that this is a neurological condition and that although they are having antidepressants, the antidepressant works in a different way at a fraction of the normal dose. So they are not afraid that they're going to get weight gain or they're going to get sedation as a result of this sort of treatment. Usually they tend to respond within about 10 days, so the pain goes away. And the pain goes away for a long period of time, usually between 1 to 3 years. Sometimes it comes back. In some patients who have very, very intense pain, I have often used Pindolol, which is a beta blocker, but also has effects on the serotonergic receptor 5-OHT1A in the brain, and it manages to reduce pain intensity, and it reduces their consumption of painkillers.
We've spoken about treatment modalities, and chronic facial pain is a topic which you've researched elaborately. It's one of your favorite subjects now. So what do you foresee in the coming future in this regard, in this particular field of medicine?
I think what we're going to foresee is as this information becomes disseminated, it is important for practitioners in the field, because they are going to see these patients who will not respond to antibiotics. And these patients with chronic facial pain have one characteristic. They very often change their general practitioner. Why? Because they have had the antibiotics, the decongestants, which give them partial relief or temporary relief, and their symptoms come back again. So they go to another practitioner, get some more antibiotics, some more decongestants. So as this work on facial pain becomes more disseminated, I hope that patients will be treated with a more open mind rather than resorting to the decongestants and the antibiotics. And pain over the face is not always sinusitis. If in doubt, therefore, it's probably best to consult a specialist in the field.
And that is your particular message to the viewer. Do you want to add something else before we wrap it up to the viewer in question?
I think this is a very human subject because we are dealing with people who have a fairly low quality of life, who are fed up. Sometimes they get depressed because of their symptoms, which are not they feel that they are not being adequately addressed or adequately treated. So as our knowledge increases, we hope that patients will be, first of all, exposed to less surgical interventions because of a presumed sinusitis that isn't there. So having surgery for no indication. And also to reduce the consumption of antibiotics unnecessarily.
Thank you, Mr. Agius. We hope that this has helped you understand more thoroughly the issue of chronic facial pain. We'll be with you with more videos almost always on the Synapse. Thank you.